Okay, so we're going to jump. Can everyone hear me?
Mm-hmm.
Yes.
Yep.
Okay, so chapter 26. Gee, we've gone through a lot since we started. The only thing that we eliminated was chapter 4, and that's going to be at the end. So we're like 3/4 done with the orientation part of it, or I would say the book part of it. Everything's going to be skills from now on after we finish this. So heat-related emergencies. So did anyone put a thought to this one, heat-related, especially when you're up in the mountain? No? Yeah. Okay. Explain how to prevent.
Skiing and exhaustion.
Okay, sounds good. How about those summer days? How about those sunny, snowy days? That's hot, isn't it?
Yeah, wearing too much clothing.
Right. And not drinking enough fluid, right?
Or too much fluids if they're alcoholic.
Yeah, that would be okay. Then you wouldn't really have to worry about getting overheated, right? So objectives, you can see what we're going to talk about to prevent heat-related illnesses, how the body adjusts to hot environment, symptoms related to the 4 types of heat-related illnesses, and to demonstrate the assessment and management of the patient who is suffering from each of the 4 types of heat-related illnesses. You would think, gee, you're out in the cold, why would we have heat-related illnesses? Ambient temperature, core temperature, heat stimulation, is that what you call acclimation? Heat index, humidity, hypothermia, and thermoregulation. Does everyone know what thermoregulation means?
Your body regulating heat or regulating the temperature.
Right, so it's normal. Let's see, hot environment requires advanced preparation. So to prevent heat-related illnesses, insufficient preparation under hot conditions can lead to heat-related illnesses. Acute heat-related medical problems can be deadly. Believe me, it can be deadly. So we're going to find out what happens to the body when you get overheated, what happens to the heart, what happens to the lungs, what happens to the mind, the brain. So this chapter will discuss heat-related illnesses, body regulation, and forms of heat emergencies, and how to assess and treat the condition. Anatomy and physiology, which we all know by now, right? What is the normal body core temperature, would you say? I know you see it on the screen, so it's 98.6. So would you say 101 is a little bit hot?
Too hot.
Okay, so if your body is too hot, how do you think you feel?
Flushed and dizzy and drained.
Mm-hmm. What do you think happens to respirations? Do they increase or decrease? Hello?
Body tries to cool itself.
Right, so would you increase your respirations or decrease your respirations?
Increase.
If you were hot, your respirations would increase, right?
Mm-hmm.
Your pulse would go up, your heart rate would go up, right?
Yes.
Okay. Let me see what it says here. Temperature of surrounding ambience. When these regulators no longer cool the body, related. In hot environments or during vigorous physical activity, which can cause excessive heat production. Excessive heat by sweating. So if you're sweating, it's good. But once you'll evaporative heat loss and dilation of blood vessels in the skin. Okay, thermoregulation is known as the process of maintaining normal body temperature. And I think we talked about that one. Sweating is the body's most important cooling mechanism. So when you stop sweating, I think you're in trouble, wouldn't you say? Hello?
Agreed.
That's
Okay.
bad.
In environments with high humidity, sweating is less effective. So humidity is an amount of water as gas, calling water vapor in the air. That's not too much to worry about. Dilation of blood vessels in the skin brings warm blood to the skin surface. Heat transfers to cold. Let me see. Body can lose heat through 4 mechanisms. Conduction. Tell me about conduction. Can anyone tell me about that? Come on. I want to hear participation.
Would that be
Directly transferring it to something. So say you're sitting on the cold ground or in cold water.
So the cold, by sitting in the cold water, is
Transfers from one thing to another.
okay. How about convection?
Transfers through the air.
Okay. How about evaporation?
but through the loss of water?
Okay. So does it go in the air? What?
Yes, in the air, through the air.
Okay. How about radiation? Hello? How about this last word? Radiant. No one wants to jump in and give me an answer to that one?
Would it be just going back into the air?
You think? Yay or nay?
It's sun.
Okay. So you're getting heat from the sun? I'm not going to answer it. You're going to answer it. I'll let you look it up, come up with something. Give me an example. You want me to pass on it till someone comes up with an answer?
The loss of heat through infrared rays.
Okay. Give me an example.
You're sitting, you're sitting in the shade
Okay.
and you cool off.
Okay. All right. Excellent. Let me see. Let me get out of this one. Let's see. The heat index is a measure of risk for heat illness. The higher the temperature, the higher the humidity, the greater risk of heat illnesses. So this is just a graph. You can look at it in your spare time. When you are like when it's over 100 or more, you're in trouble, which is the extreme danger zone. The danger zone, you'll see the difference. So we'll go to the next one. So when it says adequate hydration, what do you think that is?
Just making sure that there's enough fluid on board to compensate for any loss of fluid, like sweating or whatnot, and not have any internal temperature raising.
So would you say that if you drank a lot of beer, you're hydrated?
Not necessarily beer.
Okay. If you drank coffee, hydrated?
Nope. It's a diuretic as well.
Very good. So would you say water, electrolyte, anything has electrolytes or amino acid?
That stuff.
Okay. So during exercise in hot environments, this is how much you could lose in sweat in an hour, 1 liter. Sometimes we don't think about that. So don't go out there, start running or skiing really hard because you're a little overweight and you think if you want to get rid of that body, that fluid that you have, that you're going to lose weight. Not a good idea. So you want to make sure that you maintain hydration so that you don't have heat illnesses. And hydration to the level of activity and the temperature of the environment. So adequate preparation is required to ensure the body's heat, to regulate the mechanisms for the body's normal temperature in hot environment. Heat, let's see, improve heat, acclimation before taking a trip. So I didn't know this until I read this today, that let's say that you're going to a place that is hot and you want to be outside, that you should exercise, take your limit to 1 hour every day for several days before you go someplace that's hot. Did you know that? Anyone?
Yeah.
Now we're really pushing it in the summer here.
I didn't know that. I learned that today and other days. So during a period of exercise lasting several hours or more, salty snacks. Why salty snacks?
Sodium.
It retains the fluid.
Cooling water, yeah.
So what?
Too much, and you cramp when you lose too much sodium.
Right. That's how you get those leg cramps. Urine that is too light in color is a good indication of adequate hydration status. Anything with dark urine, you're dehydrated. Did you know that? Hello. Yeah. So I think what you have to do is go urinate first, see if you're hydrated. If the color looks good, you're okay. But if it's dark, you know you have to drink more fluids. So if you're in the sun, wear loose fitting clothing, sunblock, light clothing, and a brim hat. Did you know that? Okay, let's go here. Hyperthermia is a heat illness that includes a broad spectrum of injuries. So hyperthermia is characterized by a high core temperature. Well, 101, we talked about that. So body temperature. You see where it says body temperature, upper limit of survival, heat stroke, fever of 104 and up, that's heat stroke. Heat exhaustion. So has anyone ever experienced heat stroke?
Not fun.
No one?
No, just heat exhaustion.
I have.
So when you experience heat exhaustion, what was it like? Who am I speaking to? Steve?
Yeah.
Explain.
Oh, nauseous, clammy, lightheaded.
And what were you doing?
Well, it's been a couple times, but the the most memorable when I was a kid, I worked for a landscaper here in town, and I would mow lawns during the summer. So got heat exhaustion one day in July or August.
And what did you do for it?
Took the day off, went home, got in a cool room, drank water, rested, brought my core body temperature down.
Right. So remove yourself from the element. That is really the objective there. Mild hypothermia. Let me see, heat exhaustion, normal range is from, as you can see it, cardiac resuscitation as you go down, mild hypothermia, cardiac resuscitation, and severe hypothermia. So the body's unable to regulate when you have heat stroke. It's hard to regulate it. Your heart goes up, your heart rate goes up. I mean, you're starting to cramp, you start to lose some body function, you get a little confused. So heat exhaustion, the body's able to regulate temperatures, you can control that, but also get out of the environment. That will help a lot. Body temperature regulation compromised. That's cardiac resuscitation, that's mild hypothermia, and body unable to regulate, which is severe hypothermia. And you'll see that as we go along in the slide, which is what Sam's going to present. Extreme and untreated hypothermia can rapidly become life-threatening. Newborns, infants, especially the elderly and the obese, poor thermal regulations are at a greater risk for heat thermia. Why are newborns and infants a greater risk for hypothermia? Anyone?
Not much body surface area.
Right, exactly. And the fat also. And how about the elderly? Anyone know?
Slower reacting system.
Because what?
I would think a slower reacting system.
Right. Absolutely. Metabolism is a lot different. Patients with chronic medical conditions like heart disease, lung disease, and diabetes are at greater risk. Why are people with diabetes at a greater risk? Give me a reason.
It affects the way the body regulates itself. It's already busy regulating the sugar and glucose, so it has trouble regulating the temperature.
Does it have to do with their kidneys? Diabetes? Everyone agree? Hey, John, are you still there? Okay. How about alcohol and drugs? Did we talk about that already?
Yeah, well, the alcohol would definitely be talked about in the sense that it's a diuretic, so it's going to help remove fluid from the system.
Right. Alcohol has a tendency to change the thought process in the brain. You don't realize that you're dehydrated. You don't realize that you've been in the heat. You just keep on drinking, but you're losing it. And drugs, well, that's a numbing effect. So you just don't think about it. Of course, amphetamines, your heart is racing as it is. Cocaine's the same thing. It's racing. Some medications may cause dehydration or loss of thermoregulations. Amphetamines and cocaine have a tendency to create, your heart's racing, it's going really fast. That's the least you're thinking about. Okay, let's see what the next one is. Let's see, transferring heat to the environment or overwhelm the body's unable to tolerate the excessive heat. Illnesses from heat exposure can ensure. Heat-related syncope. What does that mean, syncope? Somebody give
Fainted.
me.
They fainted.
Fainting, right. You get overheated, you get a little dizzy, a little lightheaded, and down you go. How about heat cramps? Where would you experience that? What part of your body would you have that?
Muscles.
Muscles. Would you have it in your legs, your back, your head? Where?
Anywhere.
I would say whatever was being used the most.
Right. Usually the legs would start because you're walking. How about heat exhaustion? And I think we talked about that with Steve. You said that you were sweating, you were dizzy and nauseated. That does happen. And heat stroke, that's the deadly. Okay, let's go to the next one. Let's see what that gets. Heat syncope is a condition that originates primarily in the cardiovascular system. So it's like, what is meant by that? The cardiovascular system. What is the cardiovascular system? Somebody tell me.
Heart and lungs.
The
Oh,
what?
heart and all the veins.
The heart, exactly. So what do you think happens to the heart? Is it pumping or not pumping enough?
It's getting overworked.
Okay. Clinically defined as a temporary loss of responsiveness or fainting, which we talked about that, because of temporary loss of effective blood flow. So decreased blood flow. Let me see. So diverted into the peripheral circulation to allow heat to lose. So what do you think happens to your extremities with your heart and loss of circulation? Where is it going to?
The body compensates to protect the core.
Exactly. And what's in the core?
Heart and lungs.
Right.
Great.
All the vital organs. So why do you think you feel, okay, so we're talking about the brain. What happens to the brain when you have lack of perfusion?
Have altered mental stuff.
Feel lightheaded.
Mm-hmm. Lightheaded, altered mental status. So do you think that you could think clearly or you're a little bit confused?
Confused.
A little woozy.
Okay, very good. And what would cause feeling nauseated and lightheadedness? How about nausea? What happens when you become nauseated? What do you think causes that? I'm listening. I'm not going any further until somebody gives me an answer. So when you feel nauseated, how do you feel? Give me an example of how you feel.
Well, like you're gonna throw up.
Right? And what do you think causes that? The acids in your system? Metabolical? What? Lack of oxygen? Lack of circulation? What?
Imbalance of chemicals.
Very good. That's what I was looking for. Okay, heat cramps occur in large muscles. We already talked about that. Caused by, what is this word? Electrolyte disturbance and dehydration. So when we're talking electrolytes, what does that mean? Give me some examples of electrolytes.
Potassium.
Gatorade, Powerade.
Sodium.
Potassium. How about magnesium?
Yep.
Sodium. What else?
Yep.
Is there another one?
Minerals.
Okay, so what happens? What do you think happens to the heart when these all don't come together? You're missing something. You think you skip a beat?
Yes.
You would. especially if your sodium and your magnesium is totally off. Okay. Can be quite painful. Contraction, spasm of the muscle. Has anyone ever had leg cramps?
Oh yeah.
It's painful.
Yeah.
They don't go away. You try to rub them and they still don't go away. Of course, you can get creams to put on them to help it, but they still don't go away. Stretching, if you can call that, and rest and rehydration and electrolytes are what prevents this from happening. Okay, let's see the next one. Heat exhaustion. Exhaustion, oh, you're exhausted. Heat exhaustion is exhausted, dizziness, nausea, headache. It's the worst headache you've ever had. You can't get rid of it. It feels like your head's in a vice. Leg cramps all over, from your heel all the way to your buttocks. It doesn't stop. Excessive sweating, decreased urine output. So when you say decreased urine output, where do you think it's going? When you sweat, everything is shutting down?
Evaporating.
Okay. So your body temperature is greater than 101, but less than 104. And your level of responsiveness, that is normal, if you could say that. I've had heat exhaustion and it's not fun. So let's go into, it loses too much water, too many electrolytes, sweating results in dehydration. That could happen at the mountain. You're skiing, you don't drink enough fluids, you get dehydrated, you do get cramps, you get a little confused, you do get a headache, and you don't think about it, but it does happen. Body responds rapidly to treatment. Changes in mental status do not persist or worsen. Okay. Heat stroke. This is life-threatening. Why do you think it's life-threatening? Somebody tell me.
Cook your brain.
What happens to your brain?
It overheats.
Physiological functions shut down. So things that are supposed to be happening stop happening.
Right.
Unable to regulate.
Right. The temperature is greater than 104. So confusion. Sometimes you go unresponsive. So what do you think happens to the heart? You can already see it. Heart rate is high. High respiration. Decrease sweating and severe drop in blood pressure. So we've ran a call on this one before. Her core was 107. Ooh. Yes. Walked into her mobile home, and she was 107. We had ice bags. We had to stop someplace and get ice bags for her, but it was terrible. Totally unresponsive. It was terrible. She did survive, but I don't know on the output of, mentally or physically, but it was terrible. So heat stroke, let's see, a decreased level of responsiveness, persistent or getting worse.
Quick question, Patty. When it gets that high, because I know when it's like not that high, you just do passive cooling. So what's the temperature where you start doing the active cooling with the ice pack?
It slowly was going down, but when we got her to the hospital, it was like 103.
Okay.
So it wasn't that much, but we stopped at a store on the way to the hospital and got ice packs. Ice bags, big bag of ice.
Mm-hmm.
It was terrible. Her house was probably about 120, 25. She didn't have any in her air conditioner had failed. She lived in a mobile home, and I'm telling you, it was bad. And I had never seen it before. It was, her skin was like bloated.
Eesh.
Time to cook.
Yes, so it probably cooked her brain because, you know, the brain can only stand so much. How long she was that way for, I couldn't tell you. I just know that we got a call. Heat stroke is the most serious of illnesses. They can occur with or without exertion. The body normally shedding excessive heat, overwhelmed. If untreated, shock follows. Damage to the brain, the heart, and the blood vessels, the liver, and all of the main organs. It's untreated heat stroke can result in death. Like I said, I didn't do a follow-up on it, but it was one of the worst calls I'd ever seen. I think in that respect that, you know, people, that she didn't have, you know, air conditioning. It was the heat of it was the high of the summer, you know, when the heat was like about 115. So you can imagine living in a small area and no heat. I mean, no air conditioning. Okay, so let's do this. Heat cramps. Let's talk about this. You can see my screen, right?
Yeah.
I want some participation. Talk about heat cramps. Give me someone. And if not, I'm going to call on someone. How about Lynn? Len. Are you there?
Yeah.
Okay,
There
tell
it
me
goes.
about heat cramps. I'm going to put you in the
Um,
mix.
Just different cramping of muscles due to extreme heat, or usually due to dehydration, fluid loss.
Mm-hmm. What else? Anyone else want to jump in?
Is it one of the more early signs of elevation and dehydration? Elevated temperature, dehydration.
Okay.
Usually common in the abdomen, back, arms, and legs.
I can't hear you.
Oh, their heat cramps are most common in the abdomen, back, arms, or legs.
Right. So how can you fix heat cramps?
Fluids.
Hydrate. Electrolyte replacement.
Okay. What happens to the skin?
Well, with heat cramps, you're still sweating, so
So what do you think happens to the brain?
ages.
Starting to get a little fatigued as far as the brain goes.
Okay. All right. So would you see this in runners?
Sure.
Okay. How about heat exhaustion? Pathophysiology. What happens in heat exhaustion with the sodium? Give me somebody else. Fabio.
Yeah.
So tell me about heat exhaustion.
Yeah. So same thing. Lots of fluids, water and sodium,
Okay.
like hypovolemic status.
Okay.
Mental status, you start to get a little bit confused.
Okay.
In my case, temperature, yes, it's mildly elevated.
So what do you think the temperature would be?
Yep, probably
98,
below,
99.
yeah,
Yeah.
between 38 and 40, probably,
Okay.
I would guess.
You would guess. So would you say, would you have a concern for heat exhaustion, especially with that temperature? Is that elevated?
Yeah.
Okay. So what do you think the skin? Tell me about the skin. I know it says that, but tell me a little bit about it.
Yeah, probably get the same effect when you see heat cramps, but you get also the skin that start to get pale.
Oh, cool.
Okay, how about muscle? How about muscle cramping?
It might be connected or completely not connected. I think depends for which is the origin, the activities that the activity you're doing.
Okay.
If you are sitting under the sun, you don't get any muscle cramp, but you get heat exhaustion.
Right. So let's say that you're sitting by the pool. Would you put your body into the pool to cool yourself down, or would you stay out of it?
Depends on how confused you are.
Yeah, cool
That you
yourself
don't
down.
drown.
Yeah, I'm in the pool.
Okay, good. I like that one. Okay, someone tell me about heat stroke. Who's next? Who's going to jump in? Arzu?
Okay, so
Kimberly.
that's basically the next.
What?
So that would be the next step. Heat stroke.
Okay. Oops.
Would be the step that we hope people don't get to.
Exactly. And so that's when the body temperature is over 104.
Uh-huh.
And you're going to start to get like your skin's going to start to turn red, headache, dizziness. And then you start to like a lack of sweating and heat stroke.
Good.
I'm listening.
So then you're basically multi-organ. You can start having multi-organ dysfunction,
Right.
resulting from the exposure to heat.
Mm-hmm.
This is where they're going to be confused. They're not going to actually do what they need to do to start cooling down that temperature. They're not going to recognize the fact that this is the problem.
Passive cooling.
Mm-hmm.
Right. So do you think you can go into cardiac arrest?
Absolutely.
Yes.
Okay.
And
So
the body
something.
shuts down.
There was a young lady that passed away because she was using tanning beds too frequently. She would go between different systems. Yeah. She would go through the different sort of tanning clubs, and because they didn't track between the different clubs, if she had been there within the last 24 hours, then she got addicted to tanning. She died because of essentially heat stroke. She cooked herself.
Oh, well, you can cancel me. I won't be there. I'm sorry.
It's just like you wouldn't associate it to that, but there are some young women that believe that that's the necessary thing to do, is have that perfect golden tan, but they have no idea that by overdoing it, they're essentially giving themselves these really short sort of heat stroke type scenarios.
Well, I'll pass on that, wouldn't you say? So anyway, heat stroke, heat exhaustion, any of that is something to be concerned about. Take them out of the environment, mild cooling, passive cooling, and watch, check their vitals, make sure that they get something to rehydrate themselves. So we're going to go into patient assessment. Okay, so here we go. Address any threats to life, provide adequate protection. We already talked about that, removing the person from the sun. That's what you want to do. Okay. Patients are warm to the touch, maybe a little lightheaded, could have a little tachycardia, maybe hypotensive. Look for traumatic injuries, significant bleeding. So what is the third one? Why would you open their airway? Anyone?
If they pass out, their tongue could occlude the airway potentially.
Right. You want to check their breathing. Make sure they have a pulse. And where would you check their pulse at?
The carotid, maybe, or the femoral.
Why don't we go? What is that thing underneath the neck?
Correct.
I said carotid first. I don't know if you didn't
Okay,
hear
that's where you would check.
carotid, and if you don't have that, just go for the last one.
So if you don't, if they're not breathing, and they don't have a pulse, what are we going to be doing?
Jumping on that chest.
CPR.
CPR.
911. CPR.
Oh, no.
That's true. So are we all CPR certified?
Yep.
Yes? No?
Not currently.
Yes.
Yes.
Okay.
No, currently.
So with the new standard of CPR, let's say that you, and I'm going to take you there. Now you have a patient, you have a person, a guest, that they don't have a pulse and they're not breathing. So you're going to do CPR. So you don't have a barrier to give breaths. So what are we going to do?
Do you do the compressions only CPR?
Compressions only. That's right. Exactly.
My
Until what?
Today, do you do that? How do we determine whether we do breaths or no breaths?
Explain. Explain.
So like how do you, when you get to a patient and you need to do CPR, how do you determine whether it's okay to do compression only CPR or whether you need to do compression and breath CPR?
Okay, so would you do mouth to mouth?
If I had to.
What?
Without a barrier?
Is the scene safe?
What?
Scene is
Go ahead,
not safe.
Kimberly. Go ahead.
Well, if you don't know if that person's sick or has a disease, so you need a barrier.
Right.
Is the scene safe?
Right. And once you start pressing on that chest, totally guarantee you that something's going to come out of their mouth.
Mm-hmm.
And do you want to be doing mouth to mouth? No.
So
no. COVID, go ahead.
At any point, would we want to use an article of clothing as a shield?
No.
No.
If you can give compressions only, it's better than nothing. But I mean, I teach CPR and I would never, ever do mouth to mouth. Okay?
You need that one way valve.
Exactly. You need a barrier, a one way valve.
I had heard in a class a long time ago that you could use clothing as a shield if you had to.
You could, but now with COVID and all the things that are out there, I personally wouldn't do it. I would just do compressions alone, because that person that goes down, they usually have 3 to 4, sometimes 5 minutes of oxygen in their system. So no, just do compressions. Okay. Now, if they have a pulse and the shallow breathing, then you would get breaths, and you would do it with a BVM, which is a bag valve mask, or a pocket mask. If you had a pocket mask, you would just get breaths to maintain their breathing. But we'll go into that, okay? Let me see, where am I at? If the patient has a pulse and is breathing, maintain the airway. There we go. While conducting the secondary assessment. Very good. So, you know, they have a pulse and they're breathing, so they have a good airway. So you go into a secondary assessment. Patient receives prompt care, usually rapidly regains responsiveness. So when you give them care immediately, when you know that there's something wrong and you address that issue, they will respond. If they're not responding, then something else is needed. Heat cramps are intense, they're painful. and the affected extremities, which we know that. Abdominal cramping also may occur. You can get diarrhea. You can get severe cramping in your abdomen, which sometimes causes you to get nauseated and vomit. Self-limiting and resolve in a couple of minutes, sure. If you drink fluids. Depending on the severity of their condition, experience heat exhaustion, exhibit a variety of signs. Weakness, ability to work or participate in any activity, which we talked about, headache, anxiety, nausea, fainting, decreased appetite, tachycardia, normal, slightly elevated body temperature, warm skin, and sweating, moderate to heavy. That's an assessment of a patient. Heat stroke. Signs and symptoms of heat exhaustion, but also have significant altered mental status, can be fatal. Patient has hot, dry, flushed skin, but they're not sweating. Okay? Management. So tell me how you would manage a heat-related. Let's see. So we really went through this. Move your patient to a cooler location out of the sun, right? So heat-related illness, you suspect heat stroke, attend to any life-threatening identify in primary assessment. So when you come up on a patient, what is your first thing that you want to take into consideration?
Scene safety.
Scene safety. Give me a second one.
PPE.
Okay. So you've put on gloves, is that right? Is that what you're talking?
Yes.
And N95.
N95 because of COVID right now. What else? So what's the third thing?
Glasses.
No, that's all PPE. So now you've done that. You've seen safety, your PPE. What is next?
Initial assessment of the area.
Very good. And wouldn't you say that's seen safety? Tell me about the patient.
How are they laying?
How are they laying? And what are you looking for when you come up on them?
Are they conscious? The level of responsiveness, general appearance. Are they flushed? Are they sweating?
And what is
chest movement, breathing?
That's it. If they're breathing. If you notice that they're not breathing, what's the next thing you worry about? Airway?
Airway.
Exactly. So if you get stuck on the airway only, that's what you have to stay with. If they're not breathing, that's where you're going to go. If they have a pulse and they're not breathing adequately, what are you going to do with that airway?
Open it.
That's right. So tell me about oxygen. I'm listening.
Depending on their SAT, which you can probably, like the cap refill and like their general, inflection and stuff, you can determine whether they need, and if you assess the breathing, whether it's like something that you can do with just a cannula, rebreather, or BVM, if it's that bad.
Okay, so when you say a cannula, how high can you go with the oxygen?
6.
How many liters?
2 to 6.
2 to 6. So what kind of would you use a nasal cannula? Is that what you're talking about?
Yeah, I mean, in this case, if they are, we're still going with the fact that they're like unresponsive, and
let's say their oxygen level is at maybe 92. And you use a nasal cannula. Where would you put that? And what does it look like?
You put it on their nose and the tubes around their ears.
Okay. And then,
2 to 4.
okay, so let's say that you have 4. What would you see in the patient as far as the treatment?
It would start pinking up a little bit if it's pale.
It would what?
They'd start getting a little bit more pink, a little more color to their skin.
They would pink up. What do you think would happen to their level of consciousness?
Improve.
Improve a little bit.
So if that's all they need, then you don't have to go any further, right? So what is the leaders of a non-rebreather?
10 to 15.
Right. And does everyone know what a non-rebreather looks like?
Yes.
Okay, tell me.
It's a full, it's usually clear face mask with a bag on it, and somewhere to attach the oxygen line.
Okay.
And it covers your nose and mouth.
Okay.
And you want to fill that bag. You're going to like plug the hole over top of the bag to fill up the bag with oxygen for the non-rebreather.
What happens if the patient can't tolerate that?
Go back to the cannula.
Okay, that's very, very good. But hopefully you can talk to them and they'll listen to you.
Talk some sense into them.
Yes. Okay, so heat, syncope, remove the patient from the heat source. Patient is supine position with the legs elevated. Why? The legs are elevated 10 to 12 inches. Why is that so?
To keep the blood going to the core.
And what else? The brain. Hello, how are you? Provide supportive measures and cool non-alcoholic liquids. I don't understand why non-alcoholic liquids. Okay, heat cramps, oral electrolyte solutions. I don't think we have any. The only thing we have is like sports drinks, 50 to 50. Why would you not give, why do you think that you would cut sports drinks in half water and half sports drink?
Too much sodium.
Too sweet.
Too sweet. And what happens to the gut?
Doesn't like it. Make you nauseous. Maybe throw up.
Exactly. Exactly. Let's see. So what is this thing about a quarter to a half a teaspoon of table salt in a quart of water? I think we went over that. And why? What does that do?
Pulls the water in. The sodium draws the water into the system.
Right. And consume it slowly so you don't vomit. Well, let's see what else. Heat exhaustion. Oh, developing heat. Immediately move. We already know you want to move them, place it in comfort, elevation, remove clothing. Now, I know I don't want you to get excited here. Remove clothing and cool patient by fanning. So try not to remove all the clothing, okay? You don't want the patient to be nude, all right? So don't get any thoughts. Take all the clothing, loosen everything up, okay? High flow O2, saturation is less than 94. If patient can swallow, give them something to drink, okay? If they can't swallow, don't put anything in their mouth. And if they're not responsive, don't put anything in their mouth either. Don't put an ice cube in their mouth if they're unresponsive. In most cases, you'll improve the patient's condition. If it worsens, this patient needs to be seen by medical. Remember that. Know the distinction between heat exhaustion and heat stroke. because it's going to be on your exam. Transfer to the hospital for further evaluation. And symptoms do not clear up promptly. They need to be seen. A decreased level of responsiveness. They need to be seen. The temperature remains the same and it doesn't become less. They need to be seen. And anyone that is young, elderly, or has underlying medical conditions needs to be seen. Heat stroke, a true emergency, which you already know that. Recover from heat stroke depends on the duration of the hypothermia, which we know that. A treatment should be immediately done in the field to lower the body temperature. We know that. Notify EMS as quickly as possible for advanced life support. So definitely advanced life support. Probably a helo would go to the area. But you want to get into the hospital as soon as possible. O2, which you already know that. Let me see. You want to put, now why would you put ice packs in their armpits? And then they're going there.
Cooling.
You want to cool the core, right?
Cool the blood that's going to the rest of the body.
Right, exactly. Yeah, that brain is fried. Who carries a thermometer with them? Anyone? No?
There's one in the first aid room. Bring it
That
over.
is true. You mean no one has invested in a thermometer at home so they can check their temperature before they leave for work?
I have one of those gun things I point at my forehead.
We have the thermal. Yeah.
Yep, same here. And what does it read?
97.9. It's always low.
Yes, totally. So you can't go to work if it reads over what?
100.
100 and what, 1?
My work is 100.
Okay. So you have to check in. Do not give medications such as aspirin, ibuprofen. Does anyone know why?
Those thin the blood.
Exactly. Monitor the patient carefully for a rebounding increase in body temperature. Okay, so we've gone through this. Let me see. Heat exhaustion, heat stroke. Know this, as you can see it. It'll probably be on your test. Case study. Okay, here we go. Let's see. Okay, so I'm going to call on some people. Give me some answers. You're asked to patrol at a summer off-road bicycle race at a resort. The race starts at 10 a.m. and takes 3 hours. The morning temperatures are tolerable. Midday, the temperature reaches 90 Fahrenheit. You're stationed near the finish line, and one of the last bikers comes to the finish line. She collapses after getting off her bike. She stands, staggers over to you, bends over, panting. She asks for water and states she is hot and exhausted. Her face is flushed. What should you do? Patroller Dean.
Get her into the shade. Get her seated, get her some water, maybe an ice pack to put behind her back. Maybe pour another water down her back, cool her off. Basically just get her comfortable, out of the conditions, and cooling and resting.
Okay. Everyone agree?
And
Anything
take some
else?
vitals.
Take what?
And take some vitals.
Exactly. How about a little O2?
If she's still exasperated, after maybe drinking a bottle of water, if she's still having trouble breathing or still feels like a little out of it or dizzy, Then give her some O2.
Okay. Everyone agree? Anything?
Yes.
Yeah.
Well, let's see what happens. Well, you said that you took her out of the shade, out of the sun, put her in the shade. You did her vitals.
Mm.
Her pulse is 120 beat per minute. Her blood pressure is 100/60. And her oral temperature is 39, which is what? 103?
Yeah, she's.
So what did this tell you already?
The 103 would be very concerning.
Okay.
Can't get that cooled down with ice, then we need to transport her.
She's already into heat exhaustion.
Yeah, at that high, you're looking at transporting her when you see something that high.
Okay. So what do you think about her blood pressure? Does that concern you?
It's marginally low at this point for what she's going through.
Okay.
How old was she?
She was.
She's
I don't think did they say?
she's like 12 years old. That's, I mean,
it doesn't say.
She just finished a race. Jeez, her heart should be racing.
Okay. Yeah. So let's see. She's in the medical tent. You loosen her clothing. You have her lie down with her legs elevated. Why?
Get the fluids to the core.
Okay. Now her respirations are 20 beats per minute and her pulse is 100. So tell me about her.
That's high, but considering she just finished a race, you've got that into consideration. So.
Right, and it was 120 before, right?
Right, so she's seeing improvement.
So it's, yeah, as she's relaxing, you should see those numbers start to drop.
Okay.
What's her temperature though? We didn't get anyone.
So
yeah, that temperature still has me concerned.
Okay. So, but she'd
have a couple bags of ice on her.
Okay.
If she'll let you.
Okay. So you spray water on her, you fan her with a cardboard. She continues to rest and sip liquids for 30 minutes. Her breathing slows. She becomes more talkative. Her pulse is now 80. Is that good or bad?
Yeah, it's lowering.
Okay. Your findings suggest that she was suffering from what?
Exhaustion.
Right. She improved. So do you think she should be transported?
No.
Yeah, because of that 103.
That 103 is transportable.
Yeah, sure. that 103, she's got to go get checked out.
Okay.
Everything else is okay, but that 103 is just too high.
Okay. So what do you think they're going to do on the truck? ALS is out, or what are they going to do for her?
Fluid resuscitation type stuff.
Do they carry cooled IV fluids?
An IV.
IV. That's exactly it. She needs fluids, intravenous. Very good. I think that's it. Oh my gosh.
Repeat temperature? Dang it.
What?
We didn't get a repeat temperature.
Nope. That was it. They didn't do another temperature on her.
The fanning would have cooled her down.
Yeah. But she definitely needs to have ALS. She needs to be transported to replenish her body so that her organs will stay intact.
Yeah, that could start cooking the brain at 103.
Exactly. Even though she's responsive, that is a concern. Very well. Any questions on that? Nope. So what does that tell you? Stay hydrated continuously. Okay, we're going to have a break. I appreciate your surviving my craziness here. And we'll take a 10-minute break. It's what time is it? 7:12?
Yes.
Yeah, that's what I.
Okay. All right. Did everyone sign in?
No, I can't. I'm on my phone still.
Okay.
This is Bragg. Still here.
So how is everyone doing in class, really? What are your questions and concerns?
For Colin and myself, just getting caught up on the testing through the classroom is sort of where we're a little bit on the behind side. But
okay.
That's, I think, our biggest concern for us.
Well, go at it at your own pace. Don't get overwhelmed.
Let me get my screen all configured here. Everybody just bear with me momentarily. Oh, hang on. You don't want that. All right, let's get my cameras all set up. So chapter 26, Patty talked about heat-related emergencies. Chapter 25, we're going to be talking about the opposite of heat-related. And does anybody know what the opposite of heat is?
It's cold.
Cold, absolutely. So we're going to talk about cold-related emergencies. Sorry, I closed my door. All right, so talking about cold-related emergencies. So this is where somebody's body temperature becomes too low or their body parts freeze. So objectives for today, we're going to explain the wind chill index and how it applies to temperature. We're going to list the signs and symptoms of frost nip and frostbite. We're going to explain 2 types of hypothermia. We're going to define afterdrop. We're going to describe the assessment of a patient with cold injuries. We're going to describe 4 categories of cold exposure. We're going to demonstrate the management of patient with cold injuries, and we're going to demonstrate, or we're going to describe and demonstrate the emergency care of an avalanche victim. All right, a bunch of key terms that you need to know. We will make sure to go over all these key terms during today's lecture. All right, so overview. So starting off with the chapter's overview. So cold temperatures in combination with adequate preparation, including necessary food, clothing, and shelter, can overwhelm the body's mechanism for regulating temperature. In other words, if you don't take adequate preparations prior to going to the mountain or going into a cold temperature environment, you will get really, really cold. And what that cold can do is it can lead to a variety of medical injuries, or it can exacerbate injuries. And what we're usually going to talk about are going to be localized injuries or systemic injuries. So localized injuries, we'll talk about frost nip, frostbite. Systemic injuries, we'll talk about hypothermia and other related problems. So just a quick recap of anatomy and physiology. So Patty previously used this word thermoregulation earlier. So talking about the body's ability to maintain a normal body temperature. So really what the body is trying to do is when it gets cold is try to maintain its body temperature. And we talked earlier, it was roughly about 98.6 degrees Fahrenheit is where it wants to maintain. So how it maintains this is by sensors located in the body, which sense that, hey, something is wrong and we need to do something. The something that it does is it does one of 2 things. Either we're going to tell the body that we need to reduce heat loss, or we're going to tell the body that we need to generate heat. So to reduce heat loss, that's where we have constriction of peripheral blood vessels and where we stop sweating, which allows the skin to dry. Or we can generate heat, and that's where shivering comes into play. So if you see somebody who's shivering, they're typically cold. So when we talk about cold injuries, wind can make wind can make somebody much more susceptible to the cold. So as the wind speed increases, the relative temperature can become much worse. This is basically what we refer to as wind chill, which is the apparent temperature felt on exposed skin. So basically, as the wind goes over your skin, it drops the temperature. It makes it feel much colder than it really is. What we have on this screen is a wind chill chart. And the way that you read the wind chill chart is you look at the temperature. So we have, let's say, a temperature of like 25 degrees, and then we have the wind. So if, let's say, we have winds of 5 miles per hour at 25 degrees, it actually feels like it's 19 out. Whereas if we go with that 25 degree, but now we go to, let's say, 20-mile-an-hour winds, it may feel like it's 11 degrees out. And you see here that as you go up in wind speed, it makes the temperatures feel much colder than they really are. And then also too, we see down here that it talks about when do we see frostbite. So frostbite can set in roughly 30 minutes within these temperature ranges, and then 10 minutes and 5 minutes to exposed skin. So that's why it's very important to make sure that we have our skin covered when working in a cold environment. We want to prevent frostbite. And we're going to talk a little more about what frostbite is. So there are several common cold-related emergencies. These include frost-nip, frostbite, and primary and secondary hypothermia. So frost-nip itself is a very minor local cold injury. It basically is from local vasoconstriction of blood vessels in response to cold. And the key here, the key is that there is no freezing or permanent damage of the tissues. So pretty much that's where when you're out in a cold environment and your fingertips or your nose gets cold, but it hasn't really frozen, that's what we refer to as frost-nip. Very common areas see frost-nip include the ears, tips of the nose, fingers, and toes. So if the cause of frost-nip is getting cold, is from the cold, how do you think we treat frost-nip?
Getting out of the cold?
Yeah, getting out of the cold, warming it up. Very simple thing that you can do is you can stick your armpit or stick your hands up in your armpits. You can cover your nose, but basically the key here is getting out of that really cold environment. All right, going down the evolution of cold-related emergencies, next up we have frostbite. And frostbite is where the skin tissue actually freezes over. I like to compare frostbite to, has anybody ever pulled out a chicken breast out of the freezer? All right, if you think about that frozen chicken breast, that would be an example of frostbitten skin. And as it begins to thaw out, if you can imagine, that's what your skin is doing as it is thawing out. So frostbite, like we said, is actual freezing of the body tissue. Most commonly affects the fingers, toes, nose, ears, cheeks, and male genitalia. And but it can really affect any of the body tissues. And it can go deep. In some cases, it can go all the way to the bone. And sometimes it's not always related to the absolute temperature. It's more determined by the extent and duration of the freezing tissues. Now you see here on the screen, we actually have some photos of what frostbitten tissue looks like. And we see here the swelling that occurs from the frostbite. Now this looks like a this first A image looks like a recently de-thawed image. Whereas as you de-thaw it, we see here that we get the blistering with the fluid accumulation. But also too, take a look at these toes. Notice how those toes are black. If somebody can chime in here, what do you think the possibility is this individual is going to keep those toes?
Very unlikely.
Not good.
Yeah, not good at all. So this individual actually looks like this one here, their ring toe has already been lost. And these other ones that are completely black look like they're going to come off. In fact, I would almost argue this individual's foot is probably going to be amputated. Probably up to that line, this individual is probably losing half of their foot from frostbite. All right, so tissue injury from frostbite is produced in two ways. The first way is we can have actual freezing of the tissue, which forms ice crystals within and between the cells, which pulls water from them. And this leads to dehydration and chemical imbalances in the cell and damages the proteins themselves. Hang on 1 second, I need to reset something on my end. All right. Now, the other way that we can see frostbite occur and be detrimental to a patient is we can see it from loss of blood supply to the cells as capillaries and other small blood vessels are damaged. What happens here is this damages the surviving capillaries and veins, which results in leakage of the liquid part of the blood out into the tissue. And what happens is this causes some sludging or thickening of the blood, which basically makes it semi-solid. Think of it like a Slurpee, right? If you can imagine, or even, so I like to think of a Slurpee or even yogurt, right? Imagine like soft serve yogurt. Imagine that floating around your body, right? Would your body be able to pump that blood out of the tissues? Not at all. So this is a much more significant mechanism. If the body, with option number 1 freezes, right, it's very easy. We just rewarm it. However, the second way that frostbite can occur, we have much more going on underneath. So the key here with frostbite, all right, remember this. The earlier the earlier the freezing is discovered and reversed, the less severe the overall injury will be. Remember that. When we have frostbite setting in, we want to prevent it or we want to reverse it as early as possible. The extent of damage caused by frost nip or frostbite is determined by how deeply the cold injury penetrates the skin and underlying tissues. So, we have very superficial frostbite, that tissue, that organ, that body has a very good chance of surviving the assault. Whereas if it goes all the way down to the bone, if it goes all the way down to underlying organs, that's going to be some very severe frostbite. So when we talk about frostbite, it's categorized as to 3 different ways. We have what we call superficial frostbite or frost nip, which we already talked about, which basically talks about which affects the top layer of the skin, and we don't see any permanent damage. Then we have partial thickness frostbite, which actually is going into the upper layers of the skin, which can result in some minor damage. And then we have full thickness frostbite, which goes all the way down into the layers of the skin and may include muscle and bone. If you think about that frozen chicken breast I talked about earlier, that would be like your full thickness frostbite, right? Where, it's completely solid through and through. So moving on from frostbite, we're going to talk about hypothermia. Now, early Patty talked about hyperthermia, which was an increase in body temperature. With this, we're talking about hypothermia, which is a low body temperature. And the American Heart Association defines a low body temperature as anything less than 35 degrees Celsius or 95 degrees Fahrenheit. And this can occur when heat loss exceeds metabolic heat production and heat conservation. So in other words, we're losing more heat than what we're making. And this can occur at temperatures above freezing, especially when a person is in contact with flowing cold water or wind. So you can have hypothermia in temperatures that are above freezing. So let's say 40, 50 degree temperatures, you can't have hypothermia. Or if you're in cold water, water that's, 50, 60 degrees, you absolutely can have hypothermia set in. So hypothermia is classified as mild, moderate, and severe. So with mild hypothermia, this is usually, resulting in decreased so with mild hypothermia, if I can speak today, the metabolism, there we go, metabolism, word of the day, metabolism is going to initially increase, which is going to cause shivering, which serves to warm the body. However, as hypothermia begins to become moderate to severe, the body temperature is going to drop, which is going to cause clumsiness, stumbling, mental confusion, removal of clothing, and eventually unresponsiveness. Now, when we talk about the signs of severe or even moderate hypothermia, I like people to think about the umbels. Or I'm going to write down the screen, the umbels. So when we think about the effects of hypothermia, anytime that you have, you can add the word umbel to an activity, that means that that's a sign of hypothermia. So mumble, fumble, stumble, grumble, tumble, those are all signs of hypothermia. See here, we add the umbel after those actionable items. So anytime we see those umbels, that's going to be our key signs of hypothermia. Oftentimes, the patient is unaware of what's going on, which can further exacerbate the situation. When we talk about severe hypothermia, it's very counterintuitive, but when we're out on rescues for people with severe hypothermia, oftentimes we find them naked. And that's because they are unaware of what is going on, and their brain, and for whatever reason, they start to remove all their clothing, once again, because they don't know what's going on. So hypothermia can be divided into 2 types. One is going to be primary, and the other is going to be secondary hypothermia. So with primary hypothermia, we have 2 types. We have immersion and non-immersion hypothermia. So immersion basically occurs when we're dunked into cold water, which the body core cooling rates are fast, but the hypothermia does not occur as quickly as to be thought. It can take 30 minutes for individuals to become hypothermic after falling into a very cold water while wearing winter clothing. If the person is wearing a personal flotation device or can somehow hold his head above water. The problem is that without a life jacket, the person must tread water, but muscle function in the arms and legs can be lost after 10 to 15 minutes, and drowning can occur. Now, with non-emergent, this is what we refer to as accidental hypothermia, and it occurs more slowly, but may be accelerated by wind, rain, or snow if the person lacks adequate insulation and does not involve immersion in water. This is usually what we're going to work with. Now, we do have that potential at our resort to have emergent hypothermia. We do have a pond. I can't recall of any pond rescues, any patrollers on that know of any pond rescues we've done over the years. I'm going to go with no on that one. So usually we're going to find patients that are going to be basically cold from the outside environment. They didn't adequately prepare to be on the slopes. Secondary hypothermia occurs from systemic disorders and is frequently associated with traumatized or critically ill patients. So injury or illness is the primary problem, and hypothermia is often an associated problem, and this can be severe and life-threatening. Can somebody think about a condition where we have a primary issue, and what that primary issue is that would lead to hypothermia? So can somebody come up with a primary issue which secondarily leads to hypothermia?
An injury that leads to shock.
Okay, give me a specific one. I'm looking for a very specific injury.
Something, any sort of blood loss, so hypovolemic hemorrhagic shock.
Blood loss, I like that one.
How about burns?
Burns, that's actually the one I was looking for, but I like whoever came up with blood loss. I like that one, but burns, absolutely, right? And so the concern with burns is that we lose our body to regulate, or we lose our ability for our body to regulate the body temperature. Therefore, we can see the secondary hypothermia setting in. So we want to make sure that if patients have another condition, that we are keeping them as warm as possible to prevent the secondary hypothermia from setting in. And then after drop, this is where we have a continued drop in core body temperature, even after removal from exposure to the cold. So this occurs for a very limited time, even after rewarming measures are initiated, and it's thought to be caused by the return of cold blood from the extremities to the heart, which results in further drop in core body temperature. In some severe cases, after drop can result in shock and cardiac arrest. So let's talk about assessing patients that are really cold or may have frostbite. So what's the very first thing, and you know, we say it all the time, what's the very first thing that we need to be concerned about as rescuers?
Scene safety.
Scene safety, right? Absolutely. Most definitely. So you need to make sure that you are safe. Now, let me ask you this. What does scene safety mean to you in the hypothermia arena?
Making sure that you're staying warm and not being affected by the environment as well.
Absolutely. So making sure that you are warm and that you have adequate gear. Let me give you an example. Many years ago, we had an avalanche at our resort. I was one of the rescuers that was involved with the rescue. And while I was on the line, doing a probe line, I was not able to grip the probe with my hands because I was so cold. This is actually before I was a patroller. I was a ski instructor at the time. However, I recognized something was wrong. So, I said, hey, I need to tap out. And I was fumbling, I was stumbling, and I wasn't able to use my avalanche probe the way that I knew I should be able to. So I requested to come off the line, go down, get rewarmed, and then be put back out. So in the past, some OEC technicians have placed their jackets or clothing on a patient. However, it's better to rapidly transfer patient to a warm environment. What's the issue with giving up your jacket for a patient who's cold? What's the issue with this?
Now you're exposed.
Yeah, now you're cold, right? So how are you going to rescue somebody? I'm sorry, say it again.
I think, well, if, I mean, you're on a rescue, likelihood is that you're active. You've already like worked up a sweat, and now you're taking off your jacket, and now you're exposed. You're going to cool down so much more rapidly.
Yeah, absolutely. So we want to make sure that if we're going on a backcountry rescue, that we are adequately prepared. So we have our blankets. We actually have in our top shacks, we have what we call a cold pack. And the cold packs or hypothermia packs, I should say. The hypothermia packs are basically, we've got these backpacks with these huge sleeping bags that we can roll out. So if we do have somebody who's really cold, we can roll out the hypothermia pack to put somebody into a sleeping bag. So once we have the scene safe, we want to control excessive bleeding and then assess the patient's ABCDs just as you normally would. What do the ABC stand for?
Airway, breathing, circulation, disability.
All right, somebody give me my answer. What does ABC stand for?
Ambulate before carry.
Boom, there we go. Dean, you're on top of it. Ambulate before carrying, right? So, we want to see if the patients are able to get up, walk around, move around. That'll help give us an extent of what's going on. If they're not able to get up and move and ambulate before carrying, then we can move into our ABCs, right? Airway, breathing, circulation, and disability. So many will have an injury that's caused them to be caught out in the cold, resulting in hypothermia as a secondary problem. So for example, your patient may have a fractured femur, they may have a broken leg, they may have a dislocated shoulder, and they're not able to get up out of the cold. So we want to do our primary assessment, which is our ABCDE exam, and then we want to move into our secondary assessment, which focuses on our DCAP BTLS. And let's go over DCAP BTLS. So what did DCAP BTLS stand for?
Deformities, contusions, abrasions, punctures, burns, trauma, lacerations.
Swelling?
Swelling, absolutely. The only one I would change is T is not trauma, it's tenderness.
Okay.
Tenderness. And then we want to get a sample history. So when we talk about sample history, what are we looking for? What does sample mean?
Signs, symptoms.
Okay.
Allergies, medications, past medical history, last oral intake, and events leading up to the problem.
Amazing. Sounds good. And then we want to assess for excessive exposure of the body surface while performing a physical exam. Promotes further heat loss. So what this is saying is we want to be very careful. So for example, you're up on the ski hill, it's a nice cold day, and you have somebody who breaks a leg, you get to them. Let me ask you this, would you want to assess that leg? Would you want to cut their clothing open on the ski hill?
No.
So that's actually a yes or no answer, right? If, let's say they have a very simple isolated fracture, that is not open, then no, I wouldn't cut it, right? I'd assess to make sure it's a closed fracture. However, let's say that their fracture is open, they're bleeding out, right? Then do we want to cut the clothes off?
Oh, yeah.
Yes.
I mean, I would cut off only the clothing that we need, but not everything. I'm going to stand up here. Give me a second. My leg fell asleep. I'm feeling pins and needles, so I got to stand up. So we want to make sure that we make every effort to limit the surface area exposed. So if you don't need to expose an area, please don't. Leave it covered until we get down into a warm environment. And then we want to assess for signs of cold injury, such as frostbite. And if we see frostbite, we want to provide rapid warming. We want to provide a rapid thorough assessment of the patient is warranted. So when we talk about frost nip, the individual's skin appears cool and pale. And while frost nip may be very painful, the tissues remain intact and the skin is still pliable. Once again, this is a very minor issue that can usually be fixed by simply rewarming the area. When we get into frostbite, the earliest symptom of frostbite is usually pain. So, that pain at the injury site, although it can be variable. And then that pain is followed by numbness without pain because as the tissue freezes, sensation and pain stop. Easing of pain is often mistaken for improvement of the condition. So this can actually mask your assessment, right? If your patient says, yeah, you know, my extremity, my nose, my cheeks, my ears, you know, they were, you know, they were in pain, but now they're not, that might actually clue you in that something is going on that we need to look at. And then frostbite should be suspected if a painfully cold body part suddenly stops hurting, but is not getting warmer. The affected part may initially feel soft over time, but may become firm or woody to the touch. The best way I like to describe this is, once again, think of that chicken breast, right? You pull the chicken breast out of the freezer, you let it thaw out for a little bit. You know, it's still, you know, very, very firm, right? Feels, you know, very, you know, just frozen, I guess, kind of, you know, that kind of woody sensation. You know, that would be the best way to describe what that frozen part looks like. The affected area is initially gray or waxy and then turns pale or red depending on severity. And if the area involves the head or the face, someone other than the patient may be first to notice it. So we talked about these photos earlier, looking at the swelling that occurs. And notice there, that looks, you know, we can see that kind of waxy sensation. Notice how it's really waxy. And you know, even though it's a darker skinned individual, you know, I would say that does look a little more pale compared to the rest of their skin. Once again, we have that swelling that's going along the injury site. Down here, this looks like, we talked about how this looks like a post injury, or after they thawed it out and warmed it up. We see the blistering that's occurring, and then we also see down below how the toes appear to be very black. In fact, the ring toe looks like it's missing, and these ones are probably going to lose or be amputated. Like we said, I would suspect that this patient's, half the patient's foot is probably going to be amputated due to the damage that occurred. All right, so different categories of cold exposure. So cold patients are divided into 4 categories that can be defined by core body temperature ranges. Now, here's the key. In the field, measurement of core temperature can be difficult or impossible. Now, we are talking about a core body temperature. What is the best way to get a core body temperature?
Rectal.
What was that?
Rectal. Rectal,
absolutely. We need to get a core body temperature by taking a rectal temperature. And just a point here, they do make thermometers specifically for oral temperatures, and they do make thermometers specifically for rectal temperatures. Usually the rectal ones are red, the oral ones are blue. Does anybody know the difference between what the oral and the rectal thermometers do, or how they work? Or anybody know what the difference is between our oral and our rectal thermometers?
One tastes worse than the other.
Yes, exactly. The answer I was looking for. Yes. The rectal thermometers taste worse than the oral ones. So make sure if you see a thermometer with a red cap on it, that doesn't go in the mouth. But I don't think we have any designated rectal thermometers at the resort. However, moving into the severity. So we have cold stressed. We see here that the temperature is 95 to 97 degrees. Our patient is still alert. They're starting to shiver. They can still help themselves. As temperature begins to become mild, that's going to be 90 to 95 degrees Fahrenheit. The patient may be alert, but may be confused, and they're going to be shivering, okay? And then as hypothermia progresses down to like moderate hypothermia, that 82 to 90, we're going to see here that they're going to have a decreased level of responsiveness, all right? They may appear drowsy, but here's the thing, and this is what gets a lot of rescuers, all right, is that many times these patients, in fact, let me grab a different color of pen here. I really want to highlight this. Let's go with green. All right, these patients may not be shivering, okay? So you may come up upon a hypothermic patient that is severely hypothermic, and you may be thinking, okay, this person's not hypothermic because they're not shivering. And that's absolutely not the case. Many times a hypothermic individual who is not shivering is severely hypothermic. Also, too, when we talk about a rescue situation, these moderate or severe hypothermic individuals oftentimes appear naked or near naked when we find them. So if we're in a search and rescue type situation, we've had somebody out that's been missing for a few days, we finally find them, all right? It's very common that if they're hypothermic, we will find them naked because of the altered mental status. They think they're warm and they start taking off their clothing. And we call that paradoxical undressing. And then as hypothermia begins to get more severe, they may be unresponsive and not breathing. And we see that with body temperatures less than 82 degrees Fahrenheit. All right, so when they're cold stressed, basically temperatures, let's see here, between 95 and 97, the body is losing heat, but they're still able to compensate, and they shiver. Once again, they shiver to generate heat. And then between 90 to 95, this is going to be our mild hypothermia, and usually it manifests itself as shivering, which can be vigorous, and the shivering is an important mechanism that increases muscle activity and heat production. Initially starts when the body temperature gets below 95. And then unless other factors are present, shivering should enable you to overcome the heat loss and elevate the core. And most patients with mild hypothermia can warm themselves through shivering alone, which still require protection from heat loss. We want to protect them from heat loss. So if you're shivering, get out of the cold, protect yourself from further heat loss, and you'll be able to warm back up quickly. Going back to avalanche rescue, when I was involved in that avalanche rescue, I came off the mountain. My body temperature was 92 degrees when they took it. All right, I was really cold. So, you know, this shivering that was in place. I mean, I have never shivered so much in my life. I was so cold that night. All right, now as the core body temperature begins to fall, you're going to have uncontrolled shivering, which is going to be observed until the body temperature reaches 90 degrees Fahrenheit. So when the body starts getting below 90 degrees Fahrenheit, that shivering begins to stop. There are some exceptions to this, including exhausted patients who are unable to shiver, and some cases of chronic exposure in which exhaustion occurs and shivering does stop. Once again, just because you don't see shivering doesn't mean that patient's not cold. If you don't see shivering, that patient is severely cold. And these patients generally remain responsive, although they may be confused and exhibit both a loss of judgment and decreased fine motor coordination. As hypothermia begins to set in, we have moderate hypothermia, and that's going to be 82 to 90 degrees Fahrenheit. It's characterized by the stopping of shivering, usually once the body temperature gets below 90 degrees. A progressive slowing of metabolism occurs as evidenced by slow pulse and or respirations. And as the heart rate falls and peripheral vasoconstriction relaxes, hypotension results. In other words, the heart beats more slowly and the blood vessels in the arms and legs relax, allowing more blood in the extremities, causing blood pressure to fall. This means that we can see a decreased level of responsiveness, which can either be from decreased slurred speech to all the way to unresponsiveness, and the skin temperature gets much colder. Now, let's go back to this progressive slowing of metabolism and this decrease in heart rate. Many times, especially as you get into severe hypothermia, you are not able to detect their pulse, and you are not able to detect the respirations, right? And so that's where that saying is. You may hear saying that you're not dead till you're warm and dead. You know, if we have somebody who's cold, we need to actively rewarm them because many times patients have come back from being severely hypothermic. Now, as the temperature begins to fall, less than 82 degrees, the heart is at risk of ventricular fibrillation. And really quick, what is ventricular fibrillation?
Erratic heartbeat.
Yeah. Does ventricular fibrillation produce a pulse?
No.
No. And what would be another term for ventricular fibrillation?
Cardiac arrest?
VFib.
Yep, cardiac arrest is what I'm looking for. So if somebody's in VFib, they are in cardiac arrest. And basically, what does cardiac arrest mean to us?
Heart attack, CPR.
Heart stopped.
Yeah, their heart is stopped, right? So they're not, they don't have a pulse, and so we need to go ahead and begin CPR. So because of this VFib that can set in, we have to make sure that we handle these severely hypothermic patients gently and with great care. We don't want to jostle them around. With severe hypothermia, the mental status is depressed, which can result in coma. And as the body temperature nears 77 degrees, the patient may appear clinically dead. Now, what do we mean by may appear clinically dead? What does that mean to us?
Can't detect pulse, not breathing.
So you're right. They may not have a pulse. They may not be breathing. But read into that. May appear. What does that mean by may appear?
You may not notice the breathing or pulse because it's so weak.
Yes. Right? So their pulse, their breathing may be so weak, they have that slow decreased metabolism that, they may appear dead for all intents and purposes, but they're really not, right? They have that really slow pulse. They have those really slow respirations. And so this is where we get that saying, once again, you're not dead till you're warm and dead. We need to warm these individuals up. And so they may be unresponsive and comatose, and they may be rigid. They may be rigid without palpable pulses or discernible respirations. So with severe hypothermia, the torso is cold to the touch. Pupillary eye reflex and deep tendon reflex are diminished or absent. What do we mean? I don't think we've covered this yet, but what do we mean by deep tendon reflexes? So when we talk about deep tendon reflexes, I'm going to point my camera down. That would be like, one example is a patellar reflex. So actually let me grab something. So for example, when we talk about deep tendon reflexes, if you ever been to your doctor, right, they take the, they take that little hammer and they have you flex your knee and they bang your knee, right, and you jerk your knee. That's an example of a deep tendon reflex. All right. Where are we? So although apparently dead, the patient cannot be presumed dead unless these conditions persist after warming. Once again, you're not dead till you're warm and dead, or obvious signs of fatal trauma are present. What would be some signs of obvious fatal trauma?
Massive head injuries.
Like so massive.
Decapitation.
What was that, Kimber?
Decapitation.
Yeah, your head's not there, right? If your head's not on your body, there's no point in trying to warm me back up. You're not going to survive. I promise. All right. Yeah, so those would be examples of massive or obvious fatal trauma. And then suppression of energy-dependent processes markedly diminish oxygen and metabolic demands. So this is why patients who are really cold and very hypothermic can survive. I'm sure we've all heard about the stories of people who survived 2, 4, 6, 8 hours underwater, right, in hypothermic water. And it's from this reason right here, right, because their body does not require as much energy. As an individual becomes cold, they do not require much oxygen and glucose. So decreased requirements explain the successful resuscitation of some hypothermic victims, despite the fact that they are dead. So if we have a hypothermic individual, what do we do? So the general principles of OEC treatment apply to all cases of cold injury, regardless of cause or severity. So when we talk about these general principles of OEC treatment, what are those general principles?
Scene safety,
Scene safety.
ABCs, primary assessment, secondary assessment.
So we want to make sure our scene is safe. We want to do our ABC exam or our primary exam. And then we want to move into our secondary and do our full body exam. All right. Remember, safety is key. And then we want to correct any severe bleeding and ABCD issue. So, you know, if they're obviously bleeding, we want to stop it. If they're not breathing, we want to breathe for them. If, you know, they're not breathing adequately, we want to give them oxygen. So talking about management, we want to prevent further heat loss. So when we talk about cold injuries, that is the key, preventing heat loss and warming the patient up. In winter weather, prevention of heat loss is important for care of all patients. And I would almost go so far as to argue, not just winter weather. Think about it, right? You know, we're getting ready to move into a all year resort to where soon we're going to have all year round activities, mountain biking. I think they're talking about like a coaster thing that goes to the mountain, whatever. But, you know, if we have that mountain bike victim that is, you know, 70 degrees out, right? You know, bilateral femur fractures. It's key that we keep that patient warm. So I would argue that in any environment, we need to keep patients warm, not just in winter weather. So in the field, we want to use insulating pads beneath the patient as a base, and then add blankets while maintaining adequate exposure of the patient's airway and spine. This process will minimize convective and conductive heat loss while allowing for airway-related interventions as needed. So we want to place an insulated heat pad on the patient's head to decrease radiant heat loss. And after caring for an injury, we want to replace any clothing that was open for the exam. And a vapor barrier can be added to eliminate evaporative heat loss and to protect insulation from getting wet. Now, they talk about insulating pads. So these insulating pads, many times we'll use heat pads specifically. And what would be a concern of using a heat pad when rewarming an individual?
Burning.
What was that?
Possible burning.
Absolutely. So just be careful that you're watching that if you're going to use any kind of heat material, that you're looking to make sure that you're not burning these patients, right? How bad would that be that the patient just has a hypothermic injury and now you go too aggressive and you have the opposite and now you burn the individual? All right, so the key here, right, I think for all cold injuries, move the injured or ill patient to a shelter and out of the wind. I mean, that's really the key. If they're cold, the key there is warm them up. Ideally, we want to move them to a heated building, but if we don't have heat, like a backcountry rescue, get them out of the cold, get them out of the wind any way that we can. Sometimes in the backcountry, your only heat may be available for a fire, so we want to make sure that we have adequate ventilation of the smoke and carbon monoxide. If you can imagine, right, if you're backcountry and now you create a fire in your tent, right, A, you might burn your tent, but B, you're going to have a bunch of other problems, right? So you may survive the cold injury, but you won't survive the carbon monoxide poisoning. If the patient does have wet clothing or cold clothing, get them out of it as quickly as possible with dry clothing. And then if shelter is not immediately available, protect the patient as best you can from wind and insulate from the ground and other cold conducting surfaces. So we can do what we call passive rewarming. So once we lose heat, we can start to rewarm, and warming can be done either passively or rewarming can be done actively. So when we talk about passive rewarming, that's basically trying to keep the patient's internal body heat and basically covering the individual with a blanket, putting a hat on them. Like this little baby here, we see that they have a hat, trying to keep the head from losing all that heat. And then we see here that, you know, she's covered up in a nice, you know, long sleeve. And then we have the blanket that is surrounding the little baby. And then, so by doing this, we are passively rewarming the victim by allowing their internal body heat to be retained. And shivering is the primary passive warming mechanism for patients in the field. Oftentimes, all that's needed to warm patients who are mildly hypothermic. Now, we may have to get into active rewarming. And when we talk about active rewarming, we are doing something to rewarm them a little bit more than putting on blankets. And this basically involves the application of heat. Now, what did we say earlier? What do we be cautious about with heat? What do we ought to be careful of? Yeah, don't burn the victim. So we want to make sure that we are assessing and watching to make sure that we're not burning the individual. So we have external and external and internal ways that we can actively rewarm somebody. So externally, that would be the application of hot packs or hot water bottles to major surface areas along the body, including arterial sites, the peripheral, and the trunk. However, keep in mind, this does not provide enough heat in order to warm severely or moderately or severely hypothermic patients who are not shivering. So inside the first aid room, we can use electric blankets. And these are good, like with the crushable hot packs, I've had very bad luck with those because they just don't stay warm enough. They're usually out in like 2 to 3 minutes. So usually having some kind of electric source usually provides very good rewarming. Oh, and if you do have somebody who's like super cold, make that radio call down to the first aid room. Get that blanket on as quickly as possible in order to have it ready right when you walk in the door. Which I don't think that we have, even though they recommend this, I don't think we have heated blankets in ski patrol in our first aid room. All right, and then we can move into.
We don't.
Say again?
We do not.
That's what I thought.
Where's Mike?
So, and then we have internal ways that we can rewarm somebody, and that's usually offering warm beverages in order to rewarm them. So typically, either like, hot tea, hot chocolate, hot cocoa, something along those lines. So we want to have warm, high energy, non-alcoholic drinks, all right, and make sure that we have high energy foods containing sugar, which are usually helpful, providing that the patient is responsive, can hold the object in their hand, and can swallow without choking. This is going to be key, right? We don't want to actively rewarm somebody who's unresponsive and pour a bunch of hot chocolate down their throat. By doing this can provide fuel to the body that enables the muscles to continue to shiver, which can generate additional heat. So in moderate or severe cases, or moderate to severe cases, we may have to use aggressive warming, such as whole body warm water immersion. However, this actually,
don't aggressively warm. It's very
don't do it. Sorry, I'm a little bit ahead of myself. Don't do it. So you don't want to rewarm the entire body. And the reason why you don't want to rewarm the entire body is because it can cause this drop in blood pressure, or it can lead to ventricular fibrillation. So just be careful. When rewarming somebody, you don't want to warm them down too fast. You don't want to, dunk their body into a hot tub. Very common thing you might hear people talking about is rubbing the extremities, but it's recommended not to rub them, as this produces very little heat and may actually damage the skin underneath. So ideally, we want to rapidly transport a patient to a definitive care facility as quickly as possible. If the patient is severely hypothermic and presents without any signs of life, we need to begin treatment immediately. So if they're cold, rigid, apparently lifeless, and hypothermic, they may not actually be dead. There was something I said earlier about this, right? What's that saying I keep saying over and over again?
You're not dead till they're warm and dead.
Absolutely. You're not dead till you're warm and dead. So that apparent lack of pulse and apnea may be due to a very slow, faint heart rate and tissue rigidity. Oh, there we go. You're not dead till you're warm and dead. Said it over and over and over again. I'm even crossing. I don't know why I'm crossing now. Trying to like scribble through it. All right. So if you have that moderate to severe hypothermic patient, open the airway. We want to check to make sure that their airway is open, especially with your avalanche victims. If you have that avalanche victim, we want to open the airway and make sure that it is open. We want to check the breathing and a pulse. And we want to check the pulse and respiration. You notice here in severe hypothermia, we want to check for up to 1 minute. Why do we want to check for up to 1 minute? Well, let me rephrase that before I even ask that. What do we typically assess for? So when we check a pulse or respirations, how long are we typically assessing for?
15 seconds.
Yeah, 15 to 30 seconds. However, in this case, we want to assess for up to 1 minute. And why do we want to check for up to 1 minute?
Because it's hard to find.
Yeah, absolutely. Their pulse may be very hard to find. So if we do not detect any cardiac activity, we want to initiate CPR, we want to go ahead and begin rescue breathing with a BVM, and we want to improve oxygenation and ventilation, which may strengthen cardiac activity and make the pulse detectable. So specifically, when we talk about providing CPR to a severely hypothermic patient, we want to check with medical advisors. Chest compressions should not be initiated on any hypothermic patient with signs of life. Remember, if they have a pulse, we do not do CPR. We want to focus on heat loss prevention, which is going to be key. We also want to focus on rewarming and treatment of other injuries and rapid evacuation and transport. And we do not want to initiate chest compressions on a patient with obvious fatal injuries. All right, so if they're dead, do not begin compressions. If they're frozen, has a chest stiff wall that's so stiff compressions are impossible, or if the rescuers are exhausted or in danger, once again, we don't want to do compressions. So multiple case reports indicate survival from accidental hypothermia can still occur, even with prolonged CPR and downtimes. Patients with severe hypothermia or patients with severe accidental hypothermia and cardiac arrest may benefit from resuscitation, even in cases of prolonged downtime and CPR. So these should not be considered dead before warming has been initiated. Once again, you're not dead until you're warm and dead. So over here, this chart is pretty much giving you an algorithm talking about when people begin to see lose consciousness, when they begin to have impaired movement, and shivering, and alertness, and then what to do for each area. So for example, if they are just cold stress, we want to warm them up. If they're mildly hypothermic, we want to have them lie down for at least 30 minutes and try to rewarm them. If they're moderately hypothermic, we want to keep them from standing and walking. We don't want to give any food or drink. And the key here, we want to rewarm them. We talk about warm IV fluids. As OEC technicians, we're not going to do warm IV fluids. So that's going to come from our paramedic partners. And then if hypothermia is severe, we want to assess vital signs. With no obvious vital signs, begin CPR. All right.
With the O2 tank on the toboggan, is that going to really affect the temperature of the air that much?
I'm sorry, what was your question?
If we have if we're transporting an O2 tank on a toboggan and the tank itself is getting cold, how much does that affect the air inside? Are we giving them cold air?
Probably not.
So I've never actually even thought about that. So one of the interesting things about compressed air is compressed air, when it's compressed, I believe is actually frozen itself. So like if you have like a can of compressed air and you squirt it out, you'll see like computer air that you use like squirt out your computer. You want to be careful about aiming it like right on your components because that compressed air is frozen. I believe oxygen as well is frozen when it's compressed. And so as it then becomes to get out of the tank, because remember, in that compressed state, it's a liquid. And then as it becomes uncompressed, it turns into a gas. So I can't imagine it, because it's, a room air tank, that oxygen is really essentially frozen inside the tank. I can't imagine the external temperature to have too much of an effect. They do recommend, there are ways to rewarm that oxygen, but at the same time, like if you don't have that rewarming, I would just recommend just giving it.
Actually,
it should be.
Air gets warmer as you fill a tank, as you compress it.
Yeah, it cools off as it leaves the compressed state and expands.
So what am I thinking about? Where?
It's called adiabatic cooling. So when a gas leaves the compressed state and expands, it cools.
Okay.
So that's what you're seeing with the computer spray. So
gotcha.
The O2 in the tank should be, if it's in a heated room, it should be the same temperature as the room until it cools as it leaves and is in the outside air. Eventually, it'll cool off to the ambient air temperature.
So
that's what I'm wondering. Is there going to be that much of a difference between the air in the tank in the FAR versus in a tank that's been outside for a couple hours?
Yeah, it should be warmer that's been sitting in the FAR.
Well, it states here that O2 tanks, you should keep them insulated when they're in the cold weather, because if not, the oxygen inside will be cold to breathe.
Okay, that's what I was wondering.
Yeah.
It does. Okay, thanks.
All right. So moving into use of an AED. So AED usage may be beneficial, although protocols can vary. So temperature at which defibrillation should first be attempted in the severely hypothermic patient has not been established. However, many times you'll see this 86 degrees, which is usually kind of where we begin to see the effects of defibrillation taking place. So if they're less than 86 degrees Fahrenheit, we can give up to 3 shocks, but after that, really defibrillating isn't going to do any good. I've even seen some protocols which recommend 1 shock for a patient in VFib, and then who's hypothermic, and then you continue to rewarm them until their body temperature becomes elevated, and then once it's elevated above 86, then you continue with your regular shocks. We're going to continue chest compressions, and basically we should consult our local medical director on what to do. So we want to attach an AED as soon as possible, and if it says shock advised, we want to give a shock. And according to the AHA 2018 guidelines, it may be reasonable to perform further defibrillation attempts according to the standard BLS algorithm concurrent with rewarming strategies. So basically what that means is that as we rewarm, we're going to go ahead and continue shocking. A patient with mild hypothermia who has been adequately rewarmed and has returned to a normal mental status need not be emergently evacuated, but we do want to take care to make sure that we prevent a recurrence of that cold injury and monitor the patient to ensure resolution. So any patient who does not respond to warming, who has moderate to severe hypothermia or severe frostbite, must be evacuated as soon as possible and transported to definitive care. Evacuation must be gentle as possible to prevent VFib or additional injury during or additional tissue damage or injury. During transport, we want to continue to monitor the patient vitals, the skin underneath, especially if there's any applied heat sources, and distal circulation. What vital signs may we want to assess?
Blood pressure, heart rate.
Yeah, blood pressure, heart rate. What else?
Pulse.
How about respiratory rate? How about AVPU? What do I mean when I write AVPU on the screen?
Level of responsiveness.
Yep. So we're looking at their level of responsiveness. All important vital signs. What will be another vital sign that we want to get? Especially if somebody's been shaking and they're cold and they're altered.
Temperature.
Okay, we want to get a temp. I like that one. What else? What other vital sign might we want to get?
Pulse ox.
Okay, we'll put pulse ox up here. Not the one I'm looking for, but somebody has an altered mental status. They're cold. They've been shivering.
Capillary refill.
Not the one I'm looking for.
Sugar.
Yes, there we go. Blood sugar. So we want to check their blood glucose measurement. All right. So we want to check their blood glucose. And remember, patients who are altered, who have been cold, shivering, they may have lost a lot of sugar. So we want to make sure we replace that. We want to re-examine the patient frequently, unless doing so could increase heat loss or cause tissues to refreeze. And if this potential exists, limit their exposure. All right. So management of frost nip, it's usually treated by seeking shelter in a warm area and simply placing a warm hand or applying a chemical heat pack covered in cloth. And we don't want to rub the affected body part. Frostbite. The key to treating frostbite is rapid rewarming. Slow, gradual warming should be avoided because it is associated with greater tissue injury. Warming causes pain, sometimes severe pain, and this should be explained to the patient. Among the factors to consider when rewarming frostbitten tissues are when, where, and how warming efforts should be performed. So when do we treat frostbite? Tissues should be warmed as soon as possible following initial discovery, and in some instances prior to transport to a medical facility. And the reason why we may want to consider frostbite is this may avoid further injury. Circumstances of the lack of proper resources may prevent warming. Judgment is required when deciding when to warm frozen tissue. Warm tissues may not be allowed to refreeze because in that case, frostbitten tissue may become gangrenous. And this one's going to be key. So when we talk about rewarming frostbitten tissue, if there is any chance of that tissue becoming refrozen, then there's a 100% chance that person is losing whatever was frozen. So if their body tissue is frozen and we rewarm it and it becomes frozen again, they're losing it. So we want to make sure that when we decide to rewarm, that they are not going to be refrozen. If shelter and equipment are not available for the thawing part, do not rewarm it. So let's say that we are in some kind of backcountry rescue and we have somebody with a frozen body part. We don't want to rewarm it in the backcountry. We want to go ahead and rewarm it in the first aid room. So if you're in the backcountry and shelter and proper equipment are available, and if rapid warming is possible, there's no possibility of refreezing, then we can thaw the body part. If the decision is made not to warm the frozen body tissue, great care must be protected to prevent from further injury. For patients who have to self-evacuate, it's best to leave a foot frozen because after it's thawed, it will be too painful for walking.
Mm-hmm.
So warming should be performed in a sheltered area. Proper equipment should be available to warm the patient adequately and prevent refreezing, which is, so keep in mind, this is best done in a medical facility. However, in the backcountry and shelters such as a cabin is available, you can build a fire to heat the water, and if refreezing may not occur, a frozen body part can be thawed. The key here is that we don't want to rewarm. We see they keep talking about not re-thawing or not refreezing that body part. So as you thaw it out, we want to make sure that we remove restrictive clothing such as rings, we want to remove constrictive clothing, rings, or watches. Why do we want to remove this constricted clothing or this restricted items?
If they have swelling as everything comes back to temperature.
Yeah, swelling is going to set in. And if it's restricted, what's going to happen as that body part begins to swell?
Cut off the circulation.
Yeah, absolutely. All right. So to rewarm, we're going to prepare a warm water bath, and we want to heat that to 102 to 104. And you notice that is just above body temperature. So we're not heating too much. What can happen if we heat too much? What can happen if we use too hot of water?
Burn.
Yeah,
Burn.
Not too hot because of burns. So we want to make sure that we use that thermometer to check the temperature. And if one is not available, place your hand. If it's comfortable, move forward. If it's not comfortable, don't put the frozen part in it. And then we want to suspend the body part in the center of the warm water bath using caution, not to contact the sides or the bottom. We want to keep the affected body part in the bath for 20 to 30 minutes. We want to stir the water to keep it at a constant temperature and add warm and hot water as needed. And we want to allow the affected body part to dry if further heat loss is preventable. And we don't want to rub tissues because this can cause sloughing the skin and other tissue damage. Once the area is warmed, we can apply aloe vera ointment and dry dressings may be applied. The patient may self-administer ibuprofen or aspirin. Warming a frozen body part can cause severe pain that requires ALS for narcotic pain management. This is very painful, so make sure we have ALS coming. And then we want to place padding between the digits. So as we rewarm, we want to place something in between each finger or each toe that is rewarming. And then we want to elevate the affected body area. So let's talk about our avalanche victims. So if we have an avalanche victim, these individuals, rescue is a race against time because of asphyxiation. Many times these individuals are buried and they become asphyxiated. But hypothermia can also be a concern. So with our avalanche victims, we're worried about hypothermia and we're worried about that asphyxiation. The potential for serious trauma is also present. So we want to make sure that we assess for any kind of further body injury. This trauma may impair thermoregulation and accelerate the development of hypothermia. So when we talk about death from asphyxiation, that is time dependent. So we need to get the patient out as quickly as possible. If the person can breathe, the concern is that toxic levels of carbon dioxide will build up. So avalanche victims who are extricated within 15 minutes have a greater than 90% chance of survival. So key there, right? 15 minutes is the highest chance of survival. The potential for survival is minimal when avalanche victims are buried for more than 35 minutes or have an obstructed airway and are in cardiac arrest on extrication. So if you've been buried for 35 minutes, your airway is obstructed, or you're in cardiac arrest, you are usually not going to survive that burial. Survival beyond 35 minutes is usually dependent on whether the patient had an air pocket and could expand the chest for breathing. So initial priorities in emergency management of avalanche victims, they talk about initial priorities. They don't talk about safety. I would probably include, safety in this one first, right? And then once we get to our victim, then making sure they have an open airway, adequate oxygenation, ventilation, and controlling any external bleeding. We want to provide supplemental oxygen, and then they may have severe hypothermia. So we want to follow treatment for severe hypothermia, and we want to check pulse and respirations for up to 1 minute. The severity of hypothermia in an avalanche burial victim may be assessed by the level of responsiveness and duration of burial. If the avalanche victim is responsive, the duration is less than 1 hour, then we most likely have mild hypothermia. So basically just warm them up, and they'll be able to warm up through shivering. Development of hypothermia during an avalanche burial does not occur as quickly as cold water immersion. So that's very important, is that, if you're in the water, you're going to freeze more quickly than if you are in an avalanche. It usually takes more than 35 minutes of burial in avalanche to cause moderate to severe hypothermia. Moderate or severe hypothermia may occur in avalanche burial victims after extrication because of accelerated development of hypothermia during the cold, windy environment. So we want to make sure we handle them gently and package them using warm wraps to minimize further heat loss. So avalanche burial victims usually have a decreased level of responsiveness and are not shivering. And what did that not shivering tell us? What's the importance of that not shivering?
They're already past that stage.
Yeah, they're really cold. And they're basically, they progress to moderate or severe hypothermia, and so they need to be rewarmed in a medical setting. Unresponsive avalanche victims who are breathing are likely moderately to severely hypothermic. So avalanche burial victims extricated after burials of 35 minutes or less who are pulseless have most likely died from asphyxiation. So although it's unlikely that resuscitation efforts will be successful, begin CPR. If CPR is unsuccessful after 30 minutes, the patient is usually dead. So you should continue CPR until a higher level medical care take over. Now, what else do we want to call? What else would be important calling for this individual? What other equipment do we want?
AED.
AED.
Yes, we want to get that AED as quickly as possible. So if burial time is greater than 35 minutes and core body temperature is less than 90 degrees Fahrenheit, the victim may be severely hypothermic, and we want to continue resuscitation efforts until we get to a medical facility. Why would we want to continue these medical efforts? What's that saying I keep saying?
Not dead until he's warm and dead.
Yep, you're not dead until you are warm and dead. So, we want to make sure that we rewarm these individuals because they're not dead until they're warm and dead. All right, so that brings us to the end of the material. Let's talk about a case study. So, it's a beautiful spring day, temperatures in the low 40s. A healthy 45-year-old woman and her 18-year-old son are out for a day of skiing. 2 hours later, she falls through some soft snow into a shallow creek. Uninjured, she's easily able to extricate herself from the water, but but not before getting wet up to her chest. The two skiers continue skiing. Riding the lift, she begins shaking uncontrollably. They decide to stop outside and drink what's left in her thermos, hot chocolate and schnapps. They make it to the gondola to ride to the base area. Halfway through the 20-minute ride, she's no longer shaking, appears sleepy, and closes her eyes. At the base area, her son is unable to wake her up. You are standing at the offload ramp, and the son yells out that he needs your help. He quickly briefs you on what's going on, and you conduct your initial assessment. So, what do we think is going on with this individual? What?
Severe hypothermia.
Why do you say that?
Because she stopped shivering. She's sleepy. She's not responsive.
Absolutely. She's no longer shaking. She appears sleepy and closes her eyes. So, here's the question. She's on the gondola. What do you do?
Sure seen safety first off, so if she's on
Okay.
the gondola.
So what would be important with scene safety?
I want to get her off the gondola or get away from the gondola. It's moving.
Yeah. So the first thing I'm going to do is probably stop the gondola, right? Let's, because if I jump in that gondola and now it goes up, I don't have any help coming, at least in the, at that base area or wherever the gondola, some gondolas are, multi-stage, right? You get on at different areas. So, we want to go ahead and stop the gondola ride and, figure out what's going on, extricate her. So we want to move into our A, B, C, D, E exam. So you and another patroller move the patient from the gondola into the aid room at base. Her clothes are wet. She appears to be dead. Her skin is pale to the touch. She's unresponsive. You check her carotid pulse for 10 seconds and you identify it's very slow. What's wrong with this?
1 minute.
Yeah. We want to check for at least 60 seconds. All right. I don't know how you identify a pulse for 10 seconds and determine it's slow. I mean,
yeah,
so slow that you're feeling a beat once every 15 seconds, right? So, we want to check for 60 seconds. So there's no signs of trauma. So what do we want to do now?
Treat for hypothermia.
Get rid of the wet clothes.
So wet clothing off. What else do we want to do?
Warm her up.
Okay. So we have wet clothing off. We want to warm her. I'm looking for something else, though. What's something else that we want to move into, specifically with our A, B, C, D, E exam?
Make sure airways open.
What was that?
Make sure airways open. Patent.
Yep. So we want to make sure we open the airway and do what?
What's her respiration? Is she requiring?
Yeah, maybe consider that BVM and that oxygen. So go ahead and start oxygen and BVM and then continue with rewarming. You decide that she's very hypothermic. You arrange for ALS transport. You ensure the airway is open, insert an OPA, and use a bag valve mask for rescue breathing. Others help place the patient. Others help patient gently remove her wet clothing. You place her in a warm electric blanket. Paramedics arrive, intubate the patient, place her in cardiac monitor, and show she has an organized rhythm with slow pulse. They start IV fluids and warm with saline, and they transfer her to the ambulance, take her to the hospital. When they say they intubate her, what does that term intubate mean?
You put down the ET tube.
A tube instead of the NPA or the OPA.
Yeah, so she's getting a tube down her throat, and so we're shoving that tube all the way down her throat. All right, so at the hospital, her core body temperature is 79 degrees. What do you make of that?
Ooh.
Chilly.
She froze.
Yeah, that's super cold. She goes into VFib, AED is used, CPR started, no response to initial defibrillation or the drugs given. In the emergency department, she's aggressively warmed and eventually her heart regains a normal rhythm. She remains in the ICU for a few days and is discharged from the hospital. All right, that brings us to the end of the program. Any questions, comments, concerns, gripes, moans, and or complaints about today?
One quick question.
Yeah.
So with regards to, being worried about warming somebody too fast, I'm guessing with what's at our disposal on the mountain day to day, we don't have to ever worry about warming somebody too fast with what we have.
No, not at all.
Okay.
Good question. All right. Seeing no other questions, while Patty was lecturing, I did go through, I got all the grades updated, so everybody's grades should be up to date inside the grade book. And then I also too got chapter 25 and 26 quizzes up, so you should be able to take those. All right. Other than that, that's all I have for today. Thank you everybody for attending.
Thanks.
Thank you.
Thank you, Sam.
I lied, I have one more question.
Yeah, what you got?
Way back when it was mentioned about us putting together our own kits for the mountain. And I don't remember because I think I missed the very first part of that class, but is there a list of supplies that's recommended, and can we start buying that stuff now? Or
if I'm not mistaken, there's a list in your OEC book.
Yeah, it's in the book.
Is it? Okay.
Just depends on which one you want to go with, Alpine or.
And then I think we talked about it earlier, but we were talking about if you guys are interested, I can put together like a bulk purchase and put together equipment for everybody. So I can start working on that if you guys are interested in that.
Okay.
So with some of my bulk purchasing power, I'm able to get some pretty killer rates on supplies. So I can look to putting that together for everybody.
Okay. So if we all get together and get a list together of what we want and
yep,
get it into you. Okay.
Yep.
Appreciate it.
Yeah. Thanks.
Yeah. Thanks, guys.
That's the last question I have.
Hey, John. John says thanks for your help today, by the way. He's just getting in.
Thanks.
Yeah, anytime, as long as you bring some water next time. As long as
That's
you
what
this is
he
the
was
first
saying.
day.
He was like, yeah, I guess he was running up and down Sherwood a lot on his own. So
Yeah,
on setup, I should say, on setup. He's clarifying. I wanted to say it's going to take him to tell me what happened. But thanks for helping him out.
Yeah, of course, of course.
Hey, Sam, I got a question.
Yeah, what you got?
On back to chapter 19, I ran across this when I was doing the tests. One portion of the chapter, it says the current recommendation is to not elevate because it does not show that it helps control breathing. But in two other places in the same chapter, it lists elevating as part of the treatment for open injuries. Is there an update on whether elevating helps or not? And more importantly, how does that affect our decision on toboggan rides?
So I think so you guys should be seeing, I wrote, I have a whiteboard. You guys should be seeing my whiteboard on the screen, right?
Yeah.
So what does this acronym mean?
And they changed that. Rest, ice, compress, which is now splint. They changed compress to splint and elevate.
Does that answer your question?
But on page 409, it says, in the past, some pre-hospital authorities recommended the elevation of bleeding extremities to assist in stopping the bleeding.
Okay,
this has not been shown to control bleeding and will distract providers from the technique of direct pressure.
Yeah, so I'll stop you right there. So that's specifically talking about bleeding. So before, back in the day, when we talked about bleeding control was a 4-step process. So with bleeding control, we first applied direct pressure. Right? Then we went ahead and we then elevated. Then we went ahead and used pressure points. Right? And then we went ahead and said, okay, if none of those work, now we use a tourniquet. Okay? So with bleeding, though, we figured out that is actually not the best thing to do So what we want to actually do is with bleeding control, we want to go ahead and use direct pressure. And if we can't get it through direct pressure, then we apply a tourniquet. What we found is that elevating a bleeding injury was taking time, and people were losing blood because they were focused on elevating the wound and stopping that bleeding. Does that make sense?
Okay. So for sprains and strains and all that, we'll still elevate, just not. But it did say for an open. Yeah. Because it says for open injuries, splint all wounds and elevate the injury above the level of the heart to reduce swelling. And that's for an open injury. So the book's kind of contradicting itself.
So yeah, so
Dean, what page
Yes.
are you on? The second one that you were talking about.
The second one is on it. It listed under the rice on page 419, and then on 420, treat any open soft tissue injury with the following: control bleeding, irrigate, blah blah blah. And the last step is splint and elevate the area above the level of the heart to reduce swelling.
So the key there is preventing swelling, but in terms of bleeding control, like if you're talking about bleeding control specifically, then we're not gonna elevate for bleeding control.